Hello and welcome. My name is Ray Jones. This edited recording is a recording of a live webcast on February 16th, 2007 by Professor Mary Watkins, Deputy Vice Chancellor of the University of Plymouth, and myself, Ray Jones. I'm Professor of Health Informatics. As the live webcast included pauses for chat room discussion and lasted a whole hour, in this edited recording I've picked out some of the main points and also included some of the chat room discussion and subsequent discussion to the programme. The overview of the recording is as follows. First of all, I'm going to present the background to the study and the University of Plymouth Study of boardroom meetings. In the second file that you can find on the web, there'll be the 3 case studies from Northwest London, from Greater Ormond Street and from Medway, and in the third clip you will find a summary of the discussion. So first of all, the University of Plymouth study. This was a study of the content of board meetings. What we did was we used publicly available sources of the trust board minutes from the web, and we took a random sample of 60 trust boards. From that, we looked at their minutes, we downloaded the last set of minutes for each trust, and we went through and content analysed the minutes, putting things into different categories of types of content: administrative, clinical, financial, and so on. And we used that to identify trusts which seemed to have a higher focus on clinical content and those which had a lower focus on clinical content. We also took a subsample from the 60, from the high and the low clinical content, to check the consistency, and we took all their minutes over a whole year to check the idea of just looking at the last set. Furthermore, we took 2 trusts with high clinical content and carried out a qualitative review of their minutes. From this, you constructed a checklist from those trusts which had high clinical content, and we reviewed those factors amongst some of the low scoring trusts, again to check out the consistency of this approach. What did we find? Well, if you want full details of this study, the full report is on the Burdett website, and the address is shown there. If you just put Burdett into Google, you'll find the Burdett website easy enough. Based on 6 sets of minutes over a whole year, the range of clinical items was between 7% and 22%. So the question, I guess, is that really organisationally significant? Does it really matter that there is as low as 7% compared to those boards which had a higher focus, 22%? Personally, we would think that there is a significant difference. That this difference between 7% and 22% is actually worth investigating further to see why some trusts have relatively little clinical content in their board meetings. When we looked at the trusts in a more qualitative manner, looking at those trusts which have high clinical content, some of the things that can be identified from looking at the board minutes were that the Chief Executive Officer was much more likely to link clinical issues to all developments within the trust, so link financial change to clinical change, would link new directives from government to impact on clinical change. So the Chief Executive Officer had a major part in bringing a clinical focus to the discussion of board meetings. Another important factor seems to be the role of non-executive directors. In trusts with high clinical content, non-executive directors had a much more open and active role within the meeting, and they would question the trust board executives in an open manner, and they participated in subcommittees. When we took this approach and developed our checklist, we found that there were a number of factors which seemed to indicate trusts with a higher clinical focus in their board meetings. One was that there were more clinical staff present. Now clearly there may be a chicken and egg situation here. Are more clinical staff present because the agenda indicated that there was going to be more clinical discussion, or is it that by having more clinical staff they brought the meeting around to a focus on clinical issues? We don't know the answer to that, of course. To follow that up further, you would need to follow up minutes in a more prospective, longitudinal manner than the way we did. An interesting item was the second one there on the list. There was less use of acronyms in reporting by trusts which had a higher clinical content. This might indicate that these trusts had a much more patient-friendly, much more family, clinician-friendly way of reporting, and that was part of that whole attitude to the way they ran their meetings and perhaps the way they ran their trust. Those trusts which had more liaison with social services also were the ones which had higher clinical content. So again, it may be a much more greater focus on patients and clients. A very important one, we think, is that in trusts with high clinical content, questions were accepted from the public, and the public seemed to have a much more active role in the meeting than in those with lower clinical content. And we're going to hear later on an example of good practice in the second section on this archive from Great Ormond Street Hospital, where patients and families actually made presentations to the trust, and it's a very interesting example of good practice. And lastly, in this checklist, we found that trusts which looked at issues of infection control were more likely to have a higher clinical content. So does this small study add to our knowledge about how NHS trusts work? Well, it was a small study. It was a relatively crude method, just one aspect of the NHS trusts, their meetings. However, we did do a lot of validity checking between looking at different ways of selecting the minutes, different ways of by taking the checklist to the low trusts, by looking at the qualitative methods. We took a whole number of different ways, so we think it does have validity. And certainly the method we used can be easily checked by others because we were using publicly available sources of information, the Trust Board Minutes, which are available on the web for everybody to look at. However, we do think that further work is required to investigate possible good practices whereby Trust Board members can help to structure their activity to ensure that the business of care is given equal importance to financial performance indicators. So we're just going to finish this clip here. This study was presented along with another sponsored by Burdett at a meeting in Westminster in November 2006, and discussion at that meeting and subsequently it identified a number of good practices. 3 of these from Medway, from North West London Hospital Trust and from Great Ormond Street Hospital are presented in the second clip in this archive. And finally, some of the discussion from the live webcast on February 16th is presented in the third clip. So I'd like to thank you for taking part in this first clip. If you want further information, please do have a look at the other 2 clips. Thank you.